two approaches. Dr. Manju Anup, who's a prolific glaucoma surgeon from Giridhar Eye Institute. She'll be speaking on the matter.
Good morning all. I'll be talking on the role of laser iridotomy versus lens extraction in primary angle closure and primary angle closure glaucoma. As you all know, there is significant amount of iridotrabecular contact in different stages of angle closure disease, and this can be either a primary contact or it can be secondary to an iridolenticular contact. Both LPI and lens extraction will relieve this iridotrabecular contact when it is appositional. They do not have a role in synechial closure. Let us see the effect of laser iridotomy in angle closure. As Thomas sir already described, laser iridotomy will relieve the pupillary block and secondary angle iridotrabecular contact, open up the drainage angle and re-establish the normal aqueous drainage. In the Vellore Eye Survey on primary angle closure, Thomas et al. Have reported that only 1 of the 9 who underwent LPI progressed compared to 7 of the 19 who refused the LPI. This is another report by American Academy of Ophthalmology which was published in 2015. The authors have looked at the efficacy of LPI on anterior chamber angle width, intraocular pressure control and disease progression, and also the short and long-term complications of LPI. After analyzing 36 articles, they have concluded that LPI is currently considered as the first line of treatment for primary angle closure disease. The available evidence indicates that LPI will help to relieve significant amount of pupillary block and widens the drainage angle. It also prevents the development of acute angle closure. It has a favorable effect on IOP if there is no extensive damage. The progression to PACG is uncommon in PACS and PAC following LPI. Also, most of the complications following LPI can be managed medically for 1 or 2 weeks time, and if decided, LPI can be done immediately as an office procedure. However, angle can remain closed even after LPI in case of very narrow angles at baseline, presence of significant synechiae, thick iris, increased lens vault and anteriorly positioned ciliary body. Let us see what happens with lens extraction in angle closure disease. One of the important lens related parameter to be considered is lens vault. It is the part of the lens situated anteriorly to a plane drawn across the scleral spur. This increased lens vault will cause, in addition to the iridolenticular contact, it also causes a primary iridotrabecular contact, and it is considered as one of the important factors for the development of acute angle closure. Cataract extraction for primary angle closure disease is in practice for many years with reasonably good result, and many studies have reported an IOP reduction of about up to 30% with lens extraction in angle closure. So lens extraction will deepen the anterior chamber, widen the angle of the anterior chamber and reverse the anatomical predisposing factors. However, we need to plan the surgery and patient may take some time for the decision, and during the time patient may develop an acute angle closure. Also, acute angle closure can occur during dilatation prior to the surgery. Surgery can be challenging in case of atonic or atrophied iris or in case of an intumescent lens. Another important factor to be considered is loss of accommodation following the lens extraction. So lens extraction will remove a significant amount of the iridotrabecular contact. However, if the trabecular meshwork is already damaged, it will not address that. So predicting which angle closure disease patient will benefit from lens removal, whether it is clear or cataractous, remains uncertain. EAGLE study is one of the largest randomized controlled trial which looked at the effect of clear lens extraction in primary angle closure disease. I'm not going into the study because we have already discussed this study in many of the scientific forums. This is another major review which was published in survey in December 2020, which looked at the role of clear lens extraction in eyes with primary angle closure and primary angle closure glaucoma. They have included the Eagle study also in their analysis. And they found that though clear lens extraction is beneficial in eyes with PAC and PACG, it's technically challenging and should be performed by experienced surgeons who not only master the procedure but also able to deal with the complications. Now let us look at the literature for the LPA versus lens extraction in primary angle closure. This study analyzed around 35 parameters including the lens vault, choroidal thickness, anterior chamber angle and iris features, and they found that after lens extraction all the parameters of the anterior chamber angle were comparable to the control. But after LPA, though there was an increase in the anterior chamber depth and a decrease in the lens vault, the results were comparable to the control only for iris curvature. This is a meta-analysis which looked at comparison of phaco with laser in angle closure glaucoma. It was published last year, and they found that phaco could effectively deepen the anterior chamber and inhibit the mechanism of angle closure. However, it did not cause additional endothelial cell damage, and there is a significant reduction in IOP in the phaco group compared to LPA, and there was no significant difference in the BCVA between the two groups. However, another article which was meta-analysis which was published recently, a few months back in 2024, reported that in phaco group there was a significant decrease in the central corneal thickness and corneal endothelial cell density, and they found no difference in terms of average IOP, medication usage, visual acuity, visual field progression, synechia and gonioscopic grading. So I would say that the lens extraction may be curative to some degree. However, like many other surgical procedures, it's associated with clear lens extraction is associated with increased risk of intra and post-op complications and other socioeconomic factors compared to standard of care. So the decision should be individualized. And my personal preference would be in acute angle closure, primary angle closure or primary angle closure glaucoma with clear lens, do an LPI first, analyze after LPI, and if there is a significant amount of residual angle closure which is due to lens related factors, consider a clear lens extraction later. However, in PAC and PACG with visually significant cataract, you can consider a primary cataract extraction. Thank you.